Hello, and welcome to Well Aware with Michigan Medicine. I'm Dr. John Ayanian, the Director of the Institute for Healthcare Policy and Innovation at the University of Michigan, and the Alice Hamilton Distinguished University Professor of Medicine and Healthcare Policy. I'm pleased to join you today to moderate this webinar discussion. We've taken questions in advance, and we'll also take live questions via the Q&A feature at the bottom of your screen. Please submit questions at any time, and we will do our best to get to as many as possible toward the latter half of our event. Today's discussion will center on how COVID-19 has permeated our lives for the past 2 years and its impact on healthcare and beyond. While some uncertainty remains about the future variants and immunity, we are potentially at a crossroads, moving to a new phase of the pandemic, often described as endemic. Before we begin our panel discussion, I would note that today is the anniversary of the first person with COVID-19 being diagnosed here in Michigan. And tomorrow is the anniversary of the World Health Organization declaring COVID-19 as a pandemic. We offer our condolences to anyone joining today who has lost a loved one to COVID-19, and our support to those who continue to experience lasting health effects of this infection. Our discussion today features 4 experts connected not only by their expertise, but also by their ties to the university's Institute for Healthcare Policy and Innovation, or IHPI for short. IHPI brings together more than 675 faculty from 15 schools and colleges, all 3 University of Michigan campuses, and a broad range of fields. Together, we make up the nation's largest university-based group of researchers focused on healthcare and health policy. The grants that fuel much of our research account for over 10% of all research conducted at the university. IHPI connects us one to another and to the resources we need to make progress on the quality, safety, equity, and affordability of healthcare and efforts to improve health. Today, many of our members are applying diverse skills and expertise to address the evolving pandemic, or as some have defined our current or future state, the endemic. But what does endemic mean, and how will it shape healthcare and impact you and your communities? We often hear the terms epidemic, pandemic, and now endemic used to describe outbreaks of infectious illnesses. As the CDC outlines, an epidemic is when an area experiences a sudden increase in cases, such as the initial outbreak of COVID-19 in Wuhan, China. A pandemic is when an infection spreads to many countries and affects large numbers of people, which the World Health Organization declared for COVID-19 on March 11th, 2020. And now we are beginning to discuss an endemic phase, when COVID-19 may become a more confined but recurring infection in different areas and regions. To share their insights, I'd like to introduce our outstanding panelists. Joining us today are Dr. Emily Toth Martin, Associate Professor of Epidemiology at the School of Public Health, Dr. Kao-Ping Chua, Assistant Professor of Pediatrics at the Medical School and of Health Management and Policy at the School of Public Health, Dr. Lindsay Kobayashi, Assistant Professor of Epidemiology at the School of Public Health, and Dr. Lona Modi, the Amanda Sanford Hickey Collegiate Professor of Internal Medicine at the Med School, Professor of Epidemiology at the School of Public Health, and Research Professor at the Institute of Gerontology. To start our discussion, I'd like to invite each panelist to share their background and address the following questions before we launch into addressing questions from our audience. What does endemic mean to you? Some experts believe COVID-19 will remain with us indefinitely in some way. To what extent might this be true, and how will it affect our day-to-day lives? From a healthcare perspective, how is COVID-19 different now than it was last year or 2 years ago? What positive changes have come from the pandemic thus far, and what can we expect moving forward? And in your respective areas of expertise, what issues are emerging that people should be thinking about? Now, I'd like to welcome our first speaker, Dr. Emily Toth Martin.
Thank you, John. And thank you to the Well Aware group for inviting me to speak today and give some of my thoughts about this. So, as John mentioned, the idea of endemic has been very popular in media circles and political circles and a lot of healthcare communications lately. I've taught epidemiology for a long time, and when I teach about the idea of endemic to my students, the term is very simplistic. Sometimes it refers to whether the levels of transmission are stable without big increases. Sometimes it refers to viruses that fall into a very predictable pattern, something that we can anticipate or something we can plan for. It's important to remember, though, that endemic doesn't always mean that the virus doesn't matter or that it doesn't affect our lives. Some endemic viruses are very burdensome. Some endemic viruses can be burdensome in the US. Some endemic viruses are very, very burdensome in areas where vaccination access can be a lot lower. So it's important to keep that in mind when thinking about this term. So instead of thinking about the definition of endemic itself, I try to think about what people mean when they hope that we are in a post-pandemic endemic world. So first, I think people are expressing a recognition in the sentiment that we aren't going to fully control or eradicate COVID for a very long time. I mean, this is especially obvious as we see development of what we call an animal reservoir, more and more animals that can carry the SARS-CoV-2 virus. And this is actually an important recognition for our leaders and our communities to make, because by understanding that we will be living around COVID for a while, we can turn our attention to making sure that we have systems in place to monitor it and to begin to predict seasonal waves that may occur and to prepare for that. So I think about this akin to how we think about the weather. With good surveillance systems and when we have plans in place about how to react if the virus changes or if a wave is coming, we can be better prepared for what might come next. So despite the many infections that just happened with the Omicron wave, I actually think that this recent wave demonstrates the power of these systems. And we at U of M work really hard to support many of these surveillance systems, both in collecting data and interpreting data and doing forecasting looking ahead. And as we build these tools to help people understand COVID in their area, we were able to use things like genomic surveillance to understand when Omicron was coming to our area. And we were able to look to other communities to see how Omicron acted in those communities. We were able to, we saw in the state of Michigan, we saw a lot of rapid deployment of tests and public education and booster shots. And for all of the infections that we saw with the Omicron wave, it's important to remember that we would have seen many, many, many more without the deployment of boosters that happened. And our models showed clearly when the wave was going to hit and when it was predicted to subside. And having that kind of clarity come down. And I think that's going to be very invaluable in the next phases of the pandemic. The second sentiment that I hear when people refer to an endemic future is a hope that the virus continues to get milder over time, causing less disruption in people's lives, less risks for everyone, especially those that are most vulnerable. And it's true that Omicron did have some characteristics that were milder than previous variants. But importantly, it's also important to remember that we've clearly shown that vaccination is the way forward to ensure milder disease. So here's what I mean. When we evaluate people that have been infected with COVID, those that were vaccinated before their infection are much less likely to receive ventilator support, need care in an ICU, die from their infection, compared to unvaccinated people who are infected. So hopefully we do have a milder future for COVID ahead of us. We've worked since the beginning of the vaccine rollout to monitor vaccine effectiveness here at U of M and in many other places. And we'll continue to monitor that as the schedule evolves and as new variants emerge. But our data clearly shows that even in cases where infection happens after vaccination, those infections themselves are much less severe. And I know we're all eagerly waiting for this work to be expanded to the 0 to 5 age group as those trials approach completion and we have vaccine available for our youngest kids. So I know that this session is focused on looking forward into the next phase of the pandemic, but with those two ideas in mind, I did want to close with an acknowledgement of what many people have experienced during the pandemic. So many have lost loved ones. Many people are still living with lingering effects of COVID infection. And so as we move forward, it'll be important to do so while we maintain a commitment to the research and the care that is needed to manage the long-term effects of the first 2 years of the pandemic on our members of our communities. So with that, I'd like to hand it off to Dr. Chua to talk about the pandemic and his views and our healthcare system.
Hi there. My name is Kao-Ping Chua. I'm a primary care pediatrician and a health services researcher. My research focuses on out-of-pocket costs, the opioid epidemic, and child health. Today, I'm going to describe how the US healthcare system has responded in both positive and negative ways to two key challenges that have arisen during the pandemic: the out-of-pocket costs for COVID-19 care and the worsening epidemic of opioid overdose deaths. I will also highlight some policy options for optimizing our response to these challenges as the pandemic continues to evolve. Let's start with discussing how the healthcare system has responded positively to shield patients from the cost of COVID-19 care. So during the pandemic, Congress enacted legislation requiring insurers to fully cover the costs of several services, including COVID-19 vaccines, testing, and services associated with vaccines and testing, such as the associated visit. In addition, most private insurance and Medicare Advantage plans voluntarily agreed to waive cost sharing for COVID-19 hospitalizations during 2020. These were all welcome developments in my view, as they mitigated financial barriers to high value and potentially life-saving services. Next slide. Unfortunately, some of these changes have been short-lived. Perhaps most notably, insurers started abandoning their cost-sharing waivers for COVID-19 hospitalizations in early 2021, and almost no insurer has a waiver now. So using claims databases, we recently showed that the proportion of COVID-19 hospitalizations in which patients were billed for hospital services spiked abruptly in early 2021, as shown in this graph. Among patients who did receive bills for hospital services, the average out-of-pocket cost was approximately $4,000 for privately insured patients and $1,600 for patients with Medicare Advantage plans. This study indicates that the hundreds of thousands of Americans who were just hospitalized for COVID-19 during the Omicron surge will be facing enormous bills at a time that they may be unable to work as they recover from hospitalization. The study also raises the concern that some seriously ill patients may avoid the hospital going forward owing to cost concerns, potentially increasing the risk of death. That dynamic could affect both the vaccinated and the unvaccinated, as insurers are billing hospitalized patients regardless of their vaccination status. Next slide. To make things even worse, my research also suggests that the out-of-pocket costs for healthcare after discharge from COVID-19 hospitalization can be substantial. In a study of privately insured and Medicare Advantage patients who were hospitalized for COVID-19 between March and June 2020, we found that the average patient paid more than $700 for healthcare within 180 days of discharge, including care such as repeat hospitalizations, surgical procedures, prescription drugs, and nursing facility care. And 10% of patients paid more than $2,000 for post-discharge care. Unfortunately, unlike with hospitalizations, there has been no effort whatsoever to mitigate these substantial costs. Next slide. Given that COVID-19 outbreaks are likely to remain a fact of life going forward, my view is that Congress should take several steps to protect patients from the cost of COVID-19 care going forward. First, Congress can pass a federal mandate for insurers to fully cover the cost of COVID-19 hospitalizations, thus avoiding the possibility that severely ill patients avoid the hospital due to cost. Second, Congress could consider also whether to mandate coverage of selected costly post-discharge services such as skilled nursing facility care. And finally, Congress could permanently mandate coverage of COVID-19 testing. Right now, that mandate is tied to the public health emergency, but there will come a time in an endemic world in which this emergency will expire. We do not want the cost of testing to dissuade patients from seeking evaluation of COVID-19 symptoms, potentially contributing to another outbreak. Next slide. So I'd like to shift gears now and talk about the opioid epidemic. So unfortunately, a record 78,000 Americans died of an opioid overdose in the 12-month period ending September 2021. About 4 in 5 of these deaths involved illegal synthetic opioids like fentanyl, which is the brown line on this graph. About 1 in 6 involved heroin, and another 1 in 6 involved prescription opioids, which are the other lines on this graph. The spike in overdose deaths during the pandemic is multifactorial, but is thought to be driven by factors such as disruptions in opioid addiction treatment, social isolation, and worsened mental health. Next slide. Now, during the pandemic, the government took several steps to increase access to highly effective medications to treat opioid addiction, such as buprenorphine, a medication that can be prescribed in offices that greatly reduces the risk of opioid overdose death. For example, in 2020, the federal government allowed buprenorphine to be prescribed after a telehealth visit rather than requiring an in-person visit. As another example, current federal legislation requires clinicians to apply for a special waiver to prescribe buprenorphine. And in April 2021, the government eliminated an onerous 8-hour training requirement for the waiver in order to increase the number of clinicians who could prescribe buprenorphine. Next slide. Despite these positive developments, the system is still missing key opportunities to prevent opioid overdose deaths. So for example, in a national study of US emergency department visits between August 2019 and April 2021, we found that ED visits for opioid overdose rose sharply in the middle of 2020, as shown in this graph. Despite this, we found that only 1 in 13 patients were prescribed the overdose reversal agent naloxone within 30 days of the ED visit, while 1 in 12 were prescribed buprenorphine. In contrast, about half of patients with an ED visit for anaphylaxis were prescribed epinephrine within 30 days, even though epinephrine is also a life-saving rescue medication, just like naloxone. Next page, or next slide. The things we need to do to slow the epidemic, opioid epidemic, are certainly too numerous for me to cover in my comments right now, but I'll just highlight a few examples related to the points I've raised. First, the federal government could permanently allow buprenorphine to be prescribed without in-person evaluation. Second, rather than just eliminate the training requirement for the buprenorphine waiver, the government could just abolish the waiver altogether, as there really is no reason that clinicians should require a special waiver to prescribe buprenorphine but not other dangerous drugs. And finally, the government can minimize barriers to naloxone access, including mandating insurers to waive out-of-pocket costs for naloxone prescriptions and making naloxone available over the counter. And with that, I'll wrap up my comments and pass along to my colleague, Dr. Kobayashi.
Hello, everyone. Thank you so much for being here today. My name is Lindsay Kobayashi, and I am an assistant professor of epidemiology in the University of Michigan School of Public Health, and of course at IHPI. I come at these issues that we are discussing today as a social epidemiologist. And that means that I study how the social aspects of the world around us, things like social relationships, education, employment, poverty, inequality, get under our skin to affect our health. Over the past 2 years, since the start of the pandemic, I've been leading a cohort study of over 4,000 older adults in the United States and their experiences during the pandemic, with a specific focus on how social and economic changes during COVID-19 experiences with COVID-19 are affecting mental health, cognitive health, and well-being of older adults. And one of the main findings of this study is that we did see a high prevalence of negative mental health effects early on in the pandemic, and that these were stronger among those who lost their jobs, who transitioned to retirement during the pandemic, and those who had heavy caregiving responsibilities early in the pandemic. But at the same time, we saw that these mental health effects declined with time as people demonstrated coping strategies and resilience to the acute phase of the pandemic. And that's something I think we can feel optimistic about going forward. One thing that's really important, though, that we've seen with COVID-19 is that the pandemic has not played out equally in our population, with minority, racial, and ethnic groups, those who are socioeconomically vulnerable, who are immunocompromised, older, and who are lacking work safety and other employment protections having disproportionately higher risk of becoming ill, hospitalized, and dying with COVID-19. With that in mind, to me, endemic is difficult to describe. What I think we can expect going forward is that the virus that causes COVID-19 is going to be with us for a long time, just as the virus that caused the 1918 Spanish flu epidemic is still playing a role in seasonal influenza outbreaks, although in a descended and variant form. We will likely see further variants and regional outbreaks of COVID-19, which may be cyclical in nature and require surveillance, just as Dr. Martin spoke about, and this will be something that people should be aware of and consider with respect to both their personal risk tolerance and, importantly, the level of vulnerability of their families, friends, and communities. From the perspective of healthcare and healthcare policy, the approach that is taken to the idea of endemic COVID, now that we are more than 2 years into the pandemic, has greater consequences than what we do as individuals. As many of us are aware, the CDC, as well as many states and counties, are removing their mask mandates and other protections, and this can leave many vulnerable people at risk. One danger of endemic COVID-19 being inscribed into our collective consciousness is that we may fail to act to prevent it. If we become complacent, outbreaks will crop up again, and they will hit the most vulnerable the hardest. So when thinking as individuals in managing our day-to-day lives, this can be hard because we do need to find a way to live life, to work, travel, play, be with family and friends, and at the same time to protect ourselves and others. In the cohort study that I lead of older adults and their experiences during the pandemic, we did find that most older adults do want clear guidance from the CDC and other authorities that follows the science. And as individuals, we can follow the science to reduce risk while maintaining our day-to-day lives through vaccination, boosters, masking, testing, and changing behavior as needed based on community transmission levels to reduce risk. And this is why community surveillance is so important in many ways when thinking as individuals, because it helps us understand what levels of risk are so that we can make decisions for ourselves. From my area of expertise, I think it's important to remember that COVID-19 is not gone. Its impacts in our population are not equally distributed, and that there do remain many people who are vulnerable to the long-term effects of COVID and future infections. What we really need is both individual level and community level tools that are accessible to everyone to be part of an effective national strategy to deal with this idea of endemic COVID-19 going forward. One positive thing we have seen with this pandemic, though, thinking about this idea of endemic COVID-19 in the future, is that people are remarkably resilient. And I don't think that we will return to the uncertain and anxiety-provoking days of the early pandemic. In a recent national poll on healthy aging, which we conduct out of here at the Institute for Healthcare Policy and Innovation, my collaborators and I found that about 2 in 3 older adults aged 50 to 80 years old felt just as resilient as they did before the pandemic, finding sources of joy such as being outdoors, taking up hobbies and projects, and connecting with family and friends both in person and virtually. However, nearly 1 in 5 older adults in the United States in this poll reported feeling less resilient than they did before the pandemic. This group of people tended to be in worse physical and mental health, which highlights the vulnerability of those in poor health and with pre-existing health conditions to the negative effects of the pandemic. And this has persisted over time as we move into this endemic phase. So for us as individuals, I would say to remember that even if you are relatively protected by your ability to socially distance, to work remotely when needed, to take time away from work, your fellow community members may not be, and that we are in this together in terms of reducing transmission through vaccination and other prevention measures. And I will close off by saying that we certainly need more support for important research to characterize and address inequities in the health, social, and economic consequences of COVID-19, especially among the most vulnerable of us in the population. We have a lot of great researchers working on this here at the University of Michigan and elsewhere, and I hope that endemic COVID-19 does not mean that we still cannot take action to reduce risk and reduce inequalities in the consequences of this virus. And with that said, I'll pass things off to Dr. Lona Modi.
Hello, everyone. Good afternoon, everyone. Thank you all for joining us and being engaged in this very important topic today. And thank you to IHPI and the Well-Aware team for organizing this and inviting us. I'll briefly speak about some of our work during this and before the pandemic hit us, and then move to reflections. Next slide, please. So I'm a geriatrician. I have worked with infections and infection prevention in older adults for a long time. I think about infections as involving a host, pathogen, and the setting. A host in COVID-19, our older adults were severely impacted due to largely many reasons, age being one of them, but medical conditions such as diabetes, cardiovascular conditions, all exacerbated their risk of getting COVID-19 and having severe adverse consequences. And COVID-19 uncovered many health disparities that were decades old and systemic in nature. The virus itself, compared to many other viruses, is a fairly contagious one. We know quite a bit about transmission dynamics now, but in the early stages, we really did not know about how this virus goes from one person to the next. And we struggled defining that in early stages. And then congregate settings, such as nursing homes, were impacted quite a bit and continue to be affected by COVID-19 due to a variety of reasons, including structural reasons, process reasons, and staffing concerns in this setting, in these settings for many decades now. Next slide. Our team's interest in COVID-19 began back in 2006 when there was a lot of discussion on disaster preparedness in nursing homes and in all healthcare and community settings. We conducted a two-state survey in Nebraska, all nursing homes in Nebraska and in Michigan, and showed that only 25% had a pandemic preparedness plan. The other 25% had some form of planning built into their overall disaster planning and preparedness, and 50% had no plans at all. We published this paper along with a medical student who was training with us back in 2008 in a good journal, and then followed that up with a paper on how nursing homes should actually approach pandemic planning, with keeping in mind that at that time our mind frame was more about an influenza pandemic than a SARS-CoV-2 pandemic. That those papers received a lot of attention, and we applied for NIH funding. However, it did not get funded, and we moved to some other areas of research that were pressing in this long-term care and older adults, affecting older adults. Next slide. So when we saw the cases emerging, especially a Seattle nursing home being affected with COVID-19, on this March 10th, 2 years ago, we sent out a survey uh, to all nursing homes in Michigan, asking them about their state of pandemic preparedness and what was on their minds, what were they worried about. And we showed that certainly nursing homes were far better prepared in 2020 than in 2007 with respect to sort of having a plan for poor staffing or reduced staffing, starting to stockpile various PPE, staff education. Almost most nursing homes that responded had provided staff education as even before the first case hit. Communications were a little bit better with the local state health authorities as well as local hospitals, and they had far better access to lab facilities than before. However, they expressed worries about staff leaving as a result of pandemic and about PPE shortages. And all of that became true as our first surge came through. We sent a second survey at the peak of the first surge just a month later on April 10th. And indeed, there was a sudden drop in occupancy, nursing homes, patients and general public had a very negative view of nursing homes, and they did not want to sort of have their loved ones in there. There were incredible staff and PPE shortages. There was confusing guidance coming from all over, and there were testing issues. There was confusion regarding hospital transfers and incredible psychological consequences of restrictive visitation policies. Next slide. Over here at Michigan Medicine, and our division serves 4 different nursing homes in the area. And during that first particular surge, there were 29 cases in 4 nursing homes. We immediately conducted a comprehensive outbreak investigation and responded in terms of getting immediate full facility testing for both staff and patients, residents who were in the nursing homes, and contained the outbreak such that only 29 residents were affected. This was sort of this particular experience showed that proactive coordinated steps were critical in rapidly responding and limiting the outbreak, and it saved lives, minimized the burden of healthcare system, and saved cost. Next slide. We followed this up by understanding surface contamination in nursing homes and showed that 90% of patient rooms are contaminated with SARS-CoV-2. However, they do a fairly good job with very few common areas contaminated. These kinds of studies have helped define infection control policies in nursing homes. And next slide. So we are doing quite a bit of ongoing research, and I hope I will address a few things during the question Q&A, but these are funded by AHRQ, NIH, and philanthropy funds, and we can talk a bit later. I'm most excited about preparing our next generation, especially in research and crisis leadership. Next slide. In terms of reflections, what does endemic mean to me? Endemic would mean a constant presence and circulation of SARS-CoV-2. In the next couple of years, we will learn to recognize patterns of this virus, and we will refine our immunization schedule based on the virus, but also on the host in terms of age of the population or the settings they are in and comorbidities. Some of the positive changes in healthcare, I would like to highlight a couple of things. The first being virtual visits. Virtual visits are there are mixed feelings about it. However, I think they are here to stay, and we will only refine it to meet the expectations of the patients that we serve. There has been an incredible knowledge gain, vaccines being one of them. We were able to develop vaccines very quickly, and the nursing home deaths reduced monumentally as a result. Today, 80% plus of nursing home residents and 80% of staff are fully vaccinated. And then there are emerging issues to think about, which we'll hear more and more about in terms of evolving role of post-acute care and long-term care. Being simple in our communications, we have had a lot of confusions, missteps as a result of not having clarity to reach all that we need to reach and to monitor local trends, but return to a new normal. I'm going to stop there, and thank you very much.
So thank you to each of our four invited speakers for your insights that you've shared. Now we'd like to move to the question and discussion portion of our webinar. And we have had a number of very good questions submitted by our members of our audience in advance of the webinar. We'll also be considering questions submitted through the Q&A feature at the bottom of your Zoom screen. So just to get started, many questions have come in from our audience regarding mask wearing and precautions that people can take if they're immunocompromised or not fully vaccinated. What advice would any of you have at this stage? And Emily, I might start with you, as you've been advising public health officials throughout the pandemic, and then we can turn to others on our panel.
Absolutely. So, I think that particularly if you have vulnerabilities and are at risk of serious infection, or if you have people in your life, or even if you want to make a decision to be more cautious, we even with the ending of a lot of the mask guidance, it doesn't change the fact that masks still work to reduce your transmission. And we shouldn't forget that. So both masks in general work to reduce transmission, but we've learned a lot about higher quality masks, like using a KN95 or an N95 mask work even more to reduce your transmission. And it's a great thing to see that those tools are a lot more available than they were earlier in the pandemic. Now we can buy high quality masks that fit well at a number of places to be able to get those. And so I think it's important not to walk away from the tools that have already worked to reduce transmission, either because on an individual level you want to do this, or because you've got people in your life that you want to protect. And so that advice on the higher quality masks being more protective still stands.
Thanks, Emily. And Lona, would you add anything to that, particularly for older adults, either living at home or in nursing home settings?
Yeah, I think older adults, if they are in with their family, a few people that they know are vaccinated and not ill, I think it is okay to relax their mask use in that particular very controlled setting. But if they're going out in a grocery store or at movies where there are many people within a small area, I would still sort of advocate for using masks and using, as Emily mentioned, many sort of high quality masks that we know are present. So that would be my main advice. I would consider in nursing homes, the patients, if you're a patient yourself or a resident, to at least consider wearing masks in again congregate settings like dining areas before eating, or in physical therapy or rehabilitation. I think that's where I would fall. But it's an evolving guidance, and we should follow CDC recommendations.
During the webinar, we've had several questions come in about what we might expect in the immediate future, particularly as some of the mask mandates are being lifted in our area here in southeastern Michigan and others. Could we expect a surge like we saw it last spring of the virus? And Emily, I know you talked about some of the models that you've been developing for monitoring the pandemic. Do they provide any insight about how things might evolve with the changes we're seeing now?
Yeah, well, I mean, the good news is that the trajectory that we're on puts us at where we are, where we were at the end of last summer, and continues into, some of the low, we are on the path to be able to see some of the very low rates of hospitalization and infection like we saw in the middle of last summer, like last July. That being said, there are two things that tend to cause increases. One is when new variants come. So always watching for that. There are some kind of on the radar, but don't seem to be fully taking hold yet. And so, always keeping an eye out for new variants that might change the trajectory. But the other thing that we watch for are big changes in movement. Lots of travel, lots of gatherings. And so, during this sort of spring break and holiday timeframe right now, I wouldn't be surprised if we saw some upticks, but may not lead to a major surge. But I think that's what we need to watch. We've sort of changed the context that we're all working in. And so I think it's a good idea to keep half an eye on the numbers and sort of see where we go from here. Do we continue this downward trajectory, or do we start to see it peak back up? I do think, I'm really convinced that we are seeing more and more seasonal type patterns. And so I do hope that on the aggregate, we may see some bumps right now in the spring, but on the aggregate, we'll continue going down into the summer, I hope.
Great, thank you. Any thoughts from any other panelists about what we should be thinking in the near term? Let's shift to another question, sort of coming back to the topic of older adults. And Lindsay, you talked about the resilience of many older adults, but also the risks and vulnerabilities. And while we certainly are concerned about the risk of infection, we're also concerned about social isolation and loneliness. And how do we ensure that older adults stay socially connected, both those in the community as well as those in long-term care facilities?
That's a great question. And I think when the pandemic first hit back in March 2020, and we were living under, shelter in place orders and social distancing recommendations, we were really concerned about these really acute impacts of very severe physical social isolation. And so I think it's actually important to distinguish between social isolation and physical isolation. And what we were seeing was physical isolation, where people still may have strong and robust social networks. You can still call your friends, you can call your family members or talk on social media or video chat, but it's really kind of that in-person, face-to-face social contact that was often severely restricted early in the pandemic, especially for older adults living in institutional settings. And what was actually kind of surprising that started coming out in the data on, surveys and research studies looking at the mental health impacts of the pandemic, was we actually saw kind of an inverse or U-shaped relationship between increasing age and mental health impacts. So the oldest age groups, those in their 70s and 80s, actually tended to have better mental health than younger people and people in middle age. And we don't know exactly why this is. There's been a lot of theories, like, with older age kind of comes life experience and wisdom that might sort of provide resilience against these difficult societal and life events. But that was actually quite encouraging, because we did know at the same time that the oldest groups of adults were those who tended to be the most physically isolated early in the pandemic. So having said that, I think these impacts of social isolation for the majority of older adults actually have not been quite as bad as we expected early on in terms of translating into impacts on mental health and well-being. Having said that, I think we're definitely not going to go back to those days of shelter in place orders and very strong social distancing recommendations. So I think it's something that we are not necessarily as concerned about going forward. And as Dr. Modi said, for older adults, if you're in a family setting at home, if you're around, family members and close people who have been vaccinated and, are healthy, I think rapid testing is a great tool for this kind of family gathering or friendship gathering. I think that we can really balance, the risks of potentially being older, having comorbid health conditions, or being immunocompromised with being able to maintain face-to-face social engagement. And then with respect to kind of, congregate settings, going to the movies, going out to dinner, going to the grocery store, I think things like Dr. Martin said, keeping an eye on the community rates in your area, continuing to mask if you feel like that's needed. It does work and it is helpful. I think these are things that we can do as older adults to protect ourselves, reduce risk while living day-to-day life and maintaining social connections.
Great, thank you. And we've also had a number of questions regarding the other age, at the end of the age spectrum, the impact of the pandemic on children and their healthcare needs and developmental needs. Kao, you're a pediatrician. What are your thoughts about sort of how children are recovering from the pandemic, and what families, communities should be doing to support children and make sure, for example, that they're getting the preventive services that they're due for, and without significant cost barriers to families?
Sure. So, of course, as a pediatrician, my job is to worry about children. And I have to say there are a lot of things that are worth worrying about. I'm just going to highlight three very quickly. The first is that we know that hundreds of thousands of US children have lost parents and other caregivers during the COVID-19 pandemic. Many of them likely also have parents who are either debilitated or have lost their jobs owing to long COVID symptoms, potentially increasing the risk of child poverty. It's well known that adverse childhood experiences like those are one of the greatest predictors of poor health in adulthood. So there's a lot of reason to be concerned about, honestly, potentially disastrous long-term consequences for a lot of children in America. I'm also worried about the risks of COVID-19 to children themselves, particularly the long-term risks. CDC estimates that most US children have actually already been infected with COVID-19. And while long COVID appears to be relatively uncommon in children, even a small risk would translate into a large absolute number of children given the size of the denominator. Beyond long COVID symptoms, there are concerning studies from adults showing changes in brain MRIs after COVID-19 infection. Whether that generalizes to children and what the implications are for children over their lifetimes is unclear. It certainly needs to be investigated further. And finally, I'll just kind of mention that I'm worried about the effects of misinformation about the COVID-19 vaccine. I think that misinformation may keep us from ever achieving a really high level of vaccination in older children, and potentially will also inhibit uptake of the COVID vaccine whenever we do get a vaccine for children under the age of 5. More broadly, I'm worried that there could be spillover effects to other childhood vaccines. There's already a push in some legislatures to rescind school vaccine mandates. And even if that's not successful, I worry that the anti-vaccination movement has been able to leverage the COVID-19 vaccine debate to plant seeds of doubt about other vaccines, even among parents who previously were rock solid about routine childhood vaccinations.
Thanks. Those are some very important issues that I think we need to tackle, together as a society and within the healthcare system, but more broadly as well. Lorna, in your presentation, you mentioned the topic of surface transmission of virus in nursing homes, and we actually received a fairly specific question during the webinar today about whether we still need to be concerned about surface transmission, and either in nursing homes or in other settings. Do you have advice about that question?
So there are a couple of different elements to think about. Within nursing homes, the reason to worry about surface transmission is that if a person is ill how far their droplets can go, and thereby what kind of infection control policy needs to be there, how far whether cohorting is required, whether our older adults should be in separate room, what kind of activities they can participate in. So that is certainly going to be there. If a person has COVID-19, they should be separate from the rest of the well group, and they should have some restrictions early on for a few days. Within the main population and general population, surface contamination has not panned out as much, particularly things like cardboards and groceries. The studies have shown that they are not a big player in transmission of viruses from one person to the other. So those are my main comments about environmental contamination.
Okay, thank you. And we also had a question in advance about how the CDC defines community risk levels and how people should use this information. Emily, could you describe what that risk monitoring system is and what advice you'd have? Because COVID-19 obviously just doesn't affect individuals, it affects communities, as we've learned throughout the pandemic. And I think we'll be able to share a link to that CDC website within the chat function here as well with those viewing the webinar.
Yeah, so there have been a lot of efforts to try to use levels to try to communicate to people what level of risk is around them to kind of support their individual decision making. So we've done a lot of projects in those lines here at U of M. The CDC has done some. We've seen some national organizations do some. This new system from the CDC, what they've done is they've taken what they previously called their high level and they moved it even higher in recognition of sort of the reduced severity that vaccination provides and the kind of wider availability of testing and treatment. And so their high level is set a bit higher, but they've also now incorporated looking at healthcare capacity and looking at how many people are being hospitalized to the disease in your region. So they take this regional hospitalization information and they take your local transmission information and they make it into a level for your county. And so what this allows you to do, you can look at your county, you can look at the county that you work in, you can look at the county that you're leaving for vacation, and that helps you calibrate your own risk tolerance and say, either you may be making one set of decisions at home, depending on what the risk level is there, but then this weekend you're traveling to a county with a fundamentally higher or lower risk level over there, and then you may want to adapt your behavior and maybe take more precautions if you're traveling to a really high transmission area. So it helps work as a tool for people to kind of understand the variation in the world around them. And you see in Michigan right now, there's incredible variation. Some counties are very high, some counties are very low. It helps us trying to navigate that space as the pandemic numbers come down.
Great, thank you. And I see those links have been provided by Kara Gavin from our communications team in the chat box. So encourage people to become more informed, particularly as Emily was suggesting at times when you're traveling or if you're interested in monitoring your own local area and where it stands in terms of infection risks. So a question I want to pose to all of our panelists is one that really reflects on sort of trade-offs that we've been living with during, obviously, since the beginning of the pandemic, we've been very attuned to preventing infections and especially preventing the consequences of severe infections and the public health actions that are needed. But we also have to balance that with social and economic considerations as we move forward. And I wonder if each of you could share some thoughts about kind of how we strike the right balance between those trade-offs within your area of expertise and the area of research that you're focused. And Lindsay, I welcome you to share your thoughts first.
Sure, thank you very much. I think that's sort of a key theme of this entire webinar. And I think the key here to balancing these kind of reducing risks of contracting COVID-19, of becoming seriously ill with COVID-19 and living our lives is surveillance. Using both community level surveillance, such as this new CDC system, as well as tools that we have as individuals to reduce our risk, those are the two things that we need to have in place going forward. I think it's wonderful that the CDC has released these area level data showing the level of risk in different communities. But in order for a map like that to be accurate and make sense, we do need to have good surveillance systems in place. So that means, testing being widely available and accessible, and other tools such as wastewater testing, because there can be, we can use wastewater as kind of an early indicator of the level of risk in a community that isn't dependent on, individuals going in to get tested. So that's also very, very important at the community level. And then again, at the individual level, I think I just can't emphasize enough the importance of vaccinations, getting a booster when eligible, using tools like masking, rapid testing before getting together in large groups, or potentially for traveling as well. I think those are really important. I think those are the tools that we need to be able to socialize face to face and sort of do all the things that we want to do as part of our lives, both socially in terms of work, in terms of travel and things like that, across all age groups, I would say.
Yeah, thank you, Lindsay. And Kao, you're an expert in health policy. What do you see as some of the important trade-offs and how we might approach them as a society and a healthcare system?
I'll be honest, I find the framing of the question to be a little bit of a false choice in some ways, and I'll explain why, which is that, yes, there are public health restrictions and they do have social and economic costs, but we needn't necessarily be forced into that to be able to, we don't have to essentially just accept the idea that we're going to be forced into making that tough choice, right? We could essentially mitigate the need to impose public health restrictions that have costs simply by taking basic steps like increasing vaccination, by making sure that everybody has access to kind of low cost rapid tests, by making sure that everybody has access to high quality masks for situations in which they're needed, for example, taking public transportation and flying in airplanes. So in a lot of cases, the fact that you have to impose a public health restrictions reflects a fundamental failure to take basic mitigation steps in the first place.
Great, thank you. And Lona, what are your thoughts about this question of how we balance the public health considerations with the economic and social consequences?
Yeah, I mean, early in the pandemic, I used to always say that there is no global economy without a global public health, right? I mean, I think if there are major outbreaks happening everywhere, then our economy is going to stop and going to be severely impacted. So building on what my other colleagues said, that it is important to sort of have a responsibility to adopt a few measures so that we we can contain an outbreak early on, and thereby sort of if I do not like to wear mask, it's okay to wear it for a couple of hours where I'm in really public setting just for the greater good, is what I feel in terms of just a simple example of a trade-off. And to me, that is something that should be part of our conversation. We have to bring many other views and ideas into this conversation. It is us alone from medical fields saying that is not going to work. We have to listen to everybody. We have to understand these trade-offs as a group and not individually as a policymaker or a researcher. I do feel that starting public health education or health sciences education early on will help. So that is something that I'm thinking about as well.
Great, thank you. And Emily, we'll give you the last word on this question before we turn to our final question for the webinar.
Yeah, I think we make a lot of trade-offs in our day-to-day lives in our family. We have infections would be disruptive to the types of things that my child wants to kind of live a rewarding year this year. And so sometimes we're more cautious so that we can preserve those experiences that she doesn't want to miss.
Great. So in concluding the webinar, I'd like to ask each of you to reflect on what does the future of COVID-19 research look like? And how could philanthropy advance your ability to conduct this research that you think is important, you and colleagues here at the University of Michigan? And Lona, maybe I could start with you for that question.
Sure. I'll just give my own example. In 2007, I remember submitting a grant of pandemic preparedness, and it was not funded. We rely quite a bit on federal funding, and I think and not all our grants get funded. And so philanthropy does help answering questions that are very sort of not really risky, but innovative and high impact questions that are the time for it, which may not be recognized by the review systems that we have right now in evaluating this federal grant. So I think philanthropy has a key role to play in those kinds of high risk, high impact projects that might not necessarily be funded elsewhere. So that is one reason for me.
Great, thank you. And Emily, what are your thoughts about the role of philanthropy in the work we do?
Yeah, what I'm seeing especially happen right now is there were a lot of systems and a lot of lessons learned about how to measure the pandemic that were really thrown together almost overnight because they were needed where they didn't exist. And especially when we think about how do we take information and bring it to people in a way that they can use it for decision making. And where I see philanthropy coming into the space now is funding how do we keep those systems in place and transform them into sustainable systems that we can have forever. So they don't just go away once the crisis kind of fizzles, but we have these available. And philanthropy is really able to do that in a very transformative way instead of federal funding, as Lona mentioned, could be very incremental. So really rethinking how do we measure and communicate. Yeah.
Great, thanks. And Kao, your thoughts?
Yeah, so I mean, I think it goes without saying that there needs to be a lot of basic and clinical research to kind of improve the effectiveness of COVID-19 vaccines and therapeutics, as well as the care of patients with COVID-19. I'll speak specifically from the perspective of healthcare researchers, which is what I do. I mean, there's so many priorities in terms of an agenda ranging from assessing long-term outcomes among children and adults infected with COVID, assessing the effects of delayed and foregone healthcare during the pandemic, and assessing progress towards slowing the opioid epidemic. But in order to do this research, researchers need data that is close to real time as possible. And unfortunately, most healthcare data has at least a 1 year lag, meaning that findings are often outdated by the time that you're actually able to analyze and publish the data. The few healthcare data that are near real time are often prohibitively expensive to purchase for the average academic, as is being able to hire the staff to analyze these data. So I think philanthropy could really help by providing the funds for a center dedicated to using near real-time data to answer key healthcare questions as COVID-19 continues to evolve.
Great, thank you. And Lindsay, we'll close with your thoughts about the role of philanthropy in the work that you're doing to understand COVID-19 and other colleagues in our community.
Yeah, thank you. I think as everyone said, I think philanthropy has a very, very key role to play in reactive, fast, high risk, high reward, transformative research. That's often difficult to get funded through federal routes. That work is very incremental. With respect to thinking about mental health of older adults and health equity, I think that the philanthropy has a really big role to play in ensuring the longevity of research studies that were set up early in the pandemic to track impacts of the pandemic on mental health. And I think that we do need to actually keep an eye on tracking mental health, tracking well-being, tracking things like how do social and economic changes during the pandemic are impacting health of people as they age and health of people across the lifespan. I think, of course, doing research on improving therapeutics and vaccinations and community surveillance systems are incredibly, incredibly important, but it's important also not to ignore the overall well-being and aging of our population, because the pandemic has really impacted life in many, many impacts in many different ways as well. So I think it's important. Philanthropy has a very important role to play in ensuring the longevity of these studies going forward.
Great, thank you. And I want to thank each of our speakers for your insights and reflections today. And I want to thank all who've joined us for this webinar. To conclude our session, I'd like to introduce my colleague, Vince Cavatayo, who's the Associate Director of Development for Michigan Medicine. Vince?
Thank you, Dr. Ayanian, and thank you all for joining us today for our discussion about the evolving pandemic. We hope you all found this session informative. We're grateful for the experts from the Institute for Healthcare Policy and Innovation who shared their valuable time and expertise with us today. I also want to extend my thanks to our wonderful donor community, and a special thanks to those of you who plan to support IHPI today, especially as we approach the university-wide Day of Giving, Giving Blue Day. Support for IHPI has never been more important. Your contributions will directly impact our team's efforts to improve the quality, safety, equity, and affordability of healthcare services. We are working together across diverse disciplines to solve some of the most complex and timely healthcare challenges. We hope that you'll join us today by giving to the IHPI Healthcare Policy and Innovation Fund, which can be found by the link in the chat. As a reminder, a recording of this webinar will be sent in a follow-up email to those of you who registered. We'll try to include links and resources that were referenced during this call. Please visit the WellAware website to stay informed on this quarterly webinar series. We'll send out information soon regarding future events. Please stay safe and stay healthy. Thank you and go Blue.